Right, okay, so we'll probably start with Darren, he's close to me here. So how do you manage patients who are presenting with hip pain in different age groups?
Different age groups.
What are the signs and symptoms to look for?
Yeah, so obviously kind of more the kind of elderly, kind of looking, clearing the kind of common things are common, so looking at any kind of hip osteoarthritis, and then kind of any kind of younger populations, working down the ways, kind of your FAI type stuff, and obviously checking your favor hours, and kind of FADERs, and kind of looking at the bit more intricate stuff from the hip pathology, and then kind of the mechanism of injury, and again, common things, so greater trochanteric pain syndrome, or whatever you want to call it, gluteal tendinopathy, and then kind of looking down the kind of chain as well, so a bit more proximal hamstring and that side of things from the muscle pattern.
And how would you differentiate? So I think you mentioned with the muscle pattern or kinetic chain. So if somebody is coming with a hip pain and they've also got the back pain,
Yeah.
so what would you do?
So kind of hip and back pain, so I'll figure out which came first. Obviously through the subjective is where the real goal is, as such, in terms of the information, and then finding out which came first, and then kind of from that, kind of if there is any kind of specific morphology changes or articular changes, and stick with that from the hip point of view, because the back is just going to be a reactive side of things.
And if somebody had a chronic, for example, back pain, and then they're presenting with a hip pain subsequently or after a minor injury, so how would you, again, still the same principle, or would you?
So the same
do
principle,
anything different
you'll
with that?
treat both kind of within the rehab session, you'll kind of treat both, but depending on what the patient attributes is more of an issue to them. So if they have chronic back pain, they're probably going to be more concerned by the new onset of hip pain, so they're going to be focusing my attention on that.
And for the rehabilitation, do you do it differently for the younger population as compared to the older population, or?
Not necessarily. You can obviously be a bit more aggressive and kind of a bit more kind of younger population, but it all same as most things. It depends on kind of what their goal is. So the younger population is probably going to be work or sporting activity. So you pitch them at a kind of higher functional level.
Now again, that might be a tricky question or to answer, but if somebody, you've been referred a patient, a young female patient without a history of trauma, she presented with hip pain and she's also having clicky hips, or she's having feeling of clicking without any trauma, and you noticed some hypermobility. So how would you manage? Now again, there are different things in that. Okay,
Yeah.
How would you tease it out, and how would you manage that patient?
So kind of tease out, obviously, see kind of individually, is there any kind of specific weakness in an flexion pattern, adduction, or hip extension kind of pattern, and then kind of working from there. Identify, isolate the weaknesses, kind of focus on them, and then see how that integrates into her functional goal, whatever she wants to get back to. And then from the clicky hip side of things, be a bit more kind of here on the side of won't be sending her away doing any kind of high-end stuff just yet. And then from the clicky side of things, seeing if there is any history of dysplasia or any other kind of family-related issues.
I'm sorry, I'm asking you all the questions and all the hip-related questions, but I'll cover first, and then we'll go on to the knee and the ankle. Regarding if somebody had the surgery for the FAI, have you noticed any difference, or is there any difference in if they have a labral repair as compared to labral debridement? And if you've seen any difference in the rehabilitation afterwards, obviously they will be protected after repair.
Yeah, so there's a lot of obviously protective posturing and kind of sometimes more the education side of helping them understand it. But I'd be with the debridement, I'd be a little bit less aggressive in some of the rehab side of things. I kind of don't push them as quickly, and kind of hold off a little bit.
So for the repair.
Yeah.
So as you all appreciate that all the hip pain, especially the young patients without a history of trauma, they've all been referred to the physiotherapy. None of them get to see any of the young adult hip surgeons at the moment. So what are your criteria? So they've been referred to you. You will start, you look at them, you will start the rehabilitation. At what stage you will say, right, now you need to go and see somebody else?
So kind of referring on, so kind of again that kind of 3-month window is where I would normally kind of notice that I'm confident in my rehab protocol algorithm by 3 months that I think they should be at that certain stage of their goal, and if not, then I'd be starting to consider further onwards. And it depends obviously on the patient as well. If they are kind of pushing that they want to be seen for another consultation, second opinion, move that on a bit quicker.
Right, okay, very good. Now, again, this may or may not be relevant. Question to this. younger patients, we're not talking about in their 20s or 30s, but we're talking about 40 or 50, they have some sort of structural abnormality with their hip, and they ended up having a hip replacement, and they do want to go to sports. What, any restrictions, anything which they can't do?
I think we can be too restrictive on people, and it's kind of a case of just giving them basic understanding of what they need to kind of stages of rehab that they need to get to in terms of understanding from a strength point of view, tissue loading, and kind of getting back to training loading, so not doing too much too soon, and then kind of giving them some nice safe kind of parameters to work within. So gradually in your Tim Gabbett work, where it's talking about gradually increasing to that sweet spot of tissue loading, and then kind of working from there.
And again, is it kind of time-based, or is it kind of more the activity-based rehab before they return to sport?
I do more activity-based, and then kind of, yeah, it's more activity-based from my side.
Now, there was a big session on sports, return to sports after hip replacement at the BHS Society earlier this year. Any restriction you put on? And I think again the people, they asked them whether you let them allow to go back to skiing, and people put their hand up, but you're allowed to put any contact sport, people put their hand up. So what your thoughts are? So any restrictions, if they have a hip replacement, would you put them in any restrictions, or would just right, okay, you do whatever you want to, you can do?
Yeah, that's a good question. Yeah, I tend not to. It depends, kind of, you can always break it down to some component of that
I
sport.
think it's a
that
shared
they can
decision
impact it.
making. So again, if they ended up having any problem and you tell them that yes, you can do whatever they want. So it's a shared decision making based on their understanding, and then acceptance of taking that risk of dislocation.
And then ultimately as well, it's focusing on the positive things that they can do, not just saying very restrictive, you can't do this, you can't do that, you can't do that, because that's going to demoralize them from the rehab process, and then you've kind of lost them straight away. So it's focusing on, well, you can do this, you can't do this, or any of these positive things that I've mentioned you can do of interest to them. So then they're keeping motivated, because same as anything, if you told someone you can't do these 5 things, and you do these 2 things, you focus on the 2 things, that's what you want.
Right, now you can take a break. Okay. So, Mr. Anand already highlighted in the morning session, so a patient coming up referred to you with acute hemarthrosis of the knee, how would you manage it?
I think people who see them first, I think first thing they understand is they need to worry about anybody who has an injury and the knee is swollen. Obviously they got blood in the joint, and we mentioned in my slide there are only a handful of reasons for that. They either have a ACL injury, they have a meniscal injury where the swelling, ACL injury swelling happens pretty quickly. Meniscal injuries swelling happens kind of overnight, or they may have things like patellar dislocation or a fracture. So there are just a handful of reasons why they get a big swelling after injury. So all of these need attention. So if one is obviously which is the right place these patients need to go, because I can see some of you are in community, so they need to be sent to the right place. So most of them it's worthwhile sending to some sort of acute setup, either be it a A&E, or if you have access to a knee injury service like we have in our area, we have direct access for GPs for knee injury service, send these patients across, because they may need, most patients, especially they are young patients, they need further attention and trying to tease out what their problem is. History examination would confirm, and I think unless you are working in a specialist service, I don't think it's really very relevant for you what is the exact injury. But as long as you understand that these patients need to be sent across, and then it can be assessed further early, that's most important. In my practice, obviously, then we have to assess, and you can make a clinical diagnosis, and as required, we do a MR scan to confirm diagnosis.
Early MRI scan?
Yeah, of course. So not usually always for ACL, but early MR, there are 2 reasons I'm looking for urgent MR. One is obviously if you have a bucket handle tear, that you can identify from if you have a block to the full extension, and that's some people used to take them for straight for surgery because there was a delay in accessing MR scan, but I don't think so that's always acceptable. I've had instances where patients will be booked in the list and they block to extension, and they got an ACL injury with a bucket handle tear. You don't want to just repair the meniscus and not treat the ACL, because they go together. One stability and one adds to others. So you want to have a full diagnosis, you give a full kind of patient prognosis and plan. So I think it's important to get early MR. Other thing which gets quite often missed is patellar dislocation. If you have a patellar dislocation and the patient has a swollen knee, they quite often they have a fracture, and some of these fractures they got like a shear fracture. The piece of articular cartilage has come off. So in a young child, a 12-year-old with a patellar dislocation, with this big articular cartilage come off, that's quarter of the joint surface. So you need to think about that, and if you may not see anything on X-rays because it's only articular surface and there's no bone underneath, so X-ray would not show anything. So need to get an urgent MR for these, because if you identify it, you can fix them. So I think take home is send to somebody who can arrange urgently, because in a primary care you may not get an urgent scan.
In your mind, are there any indication to aspirate hemarthrosis?
I normally don't have time to aspirate.
But
It
would
is-
you, if
Look,
it comes
if
to that,
you aspirate, the only time you aspirate is like mostly like patients with a ACL injury. They've got, because of hematoma, they got quads inhibition and they're struggling with their movement. You don't want their muscle to become weak. You can aspirate and hopefully get them moving earlier. In a real life, that doesn't happen often. I mean, you get them moving, arrange physio, hematoma goes away. But no quarrels with people who want to aspirate. It's okay. I mean, you can confirm it whether it's a hematoma, but your history will tell you anyway.
but that was the next question leading on to the physio rehabilitation. So again, will that affect if somebody's been referred for ACL rehabilitation and they've got hemarthrosis, massive hemarthrosis? Usually it will take some time to settle. Does that make any difference in the speed of rehabilitation, or it doesn't? If it
Yeah.
doesn't, then obviously you don't need to aspirate.
Yes, it does kind of obviously impact the rehab. I think some like 20 mil or something leads to still some autogenic inhibition in your quads. So it doesn't take much kind of fluid to actually inhibit the quadriceps. So it does make a big role.
The next
Again,
question is, would you aspirate the knees, or do you aspirate the knees
No.
referred for the ACL?
no.
So aspirate for what?
So aspirate the knee for hemarthrosis if they've been referred for ACL, if it is going to make any difference.
As a routine, no.
No.
Only rarely, as I said, some people who are struggling with their mobility and rehab, but rarely, very rarely.
Next question, what are your indications for acute knee arthroscopy apart from the locked knee?
Most common acute, obviously there is quite often we end up doing this for in trauma situations. The ACL aversion is a common thing. Other thing is this osteochondral fragments which needs fixing. Once you identify where it is, need that. Very often we do it for trauma, fracture dislocations as well. So those are the reasons to do acute one.
So, a middle-aged patient has been presented with knee pain without trauma. Now again, obviously I think before he gets to you, he probably will have the physio, he will have the MRI scan. But let's say if he's been referred to Darren, then what would be your indication for MRI scan in patients who doesn't have any trauma, he's got medial joint line pain, there is no history of trauma? What would be your indication for getting an MRI scan? Is it a failure to proceed, or wait for 3 months, 6 months, or the patient is happy to go somewhere?
Yeah,
How
so
do you get a
kind
scan?
of obviously looking at the kind of any red flags, so you're kind of giving way, locking, and then kind of any kind of acute trauma as well. So and they're kind of main things that would indicate going referring on. But then if it is a case that they're not responding to treatment as you would expect, and then kind of looking at night pain as well. So if it is kind of quite severely limiting them, then I'd be kind of referred.
Because another patient has been presented to you, he had privately, he had a report of the MRI scan which says an undisplaced posterior horn medial meniscal tear, and he's been having knee pain, medial knee pain on exertion activity. So what would you do? What would you offer him?
Privately.
It's privately. So he had a private scan.
It's the
It's coming
same
privately.
practice. You think that's the problem with the MR scan, and that's why that we're talking about this older degenerative meniscus tear. I mean, abnormal findings are normal in MR scan in this patient. Worse, their arthritis is more likely they have a meniscus tear. So first thing is obviously get an X-ray done for these patients. If they have arthritis, most likely you don't need an MR. Unless you want to operate on these patients, then you get MR, they'll show a meniscal tear, and then you operate, make your money. But you don't need to say this patient. Most difficult problem is they come with a diagnosis with a MR scan, and they think that a meniscal tear is the source of their pain, and you end up spending hours trying to explain them. Look, it's not your meniscal tear. You got arthritis. They go hand in hand. And even if somebody deals with a meniscal tear, your arthritis is still there, and your pain won't go away. So it's a lot of discussion happens with these patients. They're difficult patients. They don't want to. They think their knee will still be what they were 20-year-old. I think sometimes you just have to explain to them. I'm afraid your knee is not same when you were 20. it's likely to so anticipate their explanation and kind of setting their expectation is really important. Quite often in real terms you end up scoping these patients eventually with a variable outcome, but avoid really. I mean, most of these patients I would end up offering injection and physiotherapy as their primary modality, and then try to discharge them straight away. If you see them again, then
You're gonna do the scope.
Yeah.
Right, okay, so that was the next question. So for the injections, it's just a steroid injection you give, or you give hyaluronic acid, or you give any biologics at all?
We're not allowed to give hyaluronic anymore. Yeah.
So,
it's,
but again,
it's been
in the-
defunded kind of everywhere.
Talking about the generality of things, so not in the NHS practice. Let's say if you
Yeah.
do it,
So look, in first instance, I would always give steroid. I mean, I think, but it's part of a package. Steroid on itself is not the treatment, but why I use steroid is it reduces the pain and it helps them engage more with their physiotherapy, which is actually what's going to do the right thing for them. So that's the only reason to inject them. Hyaluronate, it's if available for some patients and they don't have much degenerative changes, I use for those patients. There is much more evidence now for PRP injection rather than this, and we're trying to make a case as for this because NICE has now approved PRP for treatment of osteoarthritis in these patients, so hopefully that might be something which we need to do more in future.
and for those injections, now again, certain people have certain criteria that how frequently they can repeat them. And again, if they have repeated and if they needed any further surgery, they will delay the surgery. You got anything?
Okay, as I said, I don't do injection as a treatment. Okay, it's only if they have either somebody's got an acute flare up and said just want to give them enough kind of pain relief to get physio. So in my practice, it's very unusual that patients keep on coming back for repeat injection. That's not. I don't think so it's the right practice. If either you make a diagnosis, identify treatment, or give them something like physio, or just tell them there's nothing else we can do for you. So repeated injection is unusual. As just for the question whether how often you can repeat them.
For the GPs,
There are things about, yeah, you said that you don't do more than 3 in a year. There's not much evidence behind it, but yeah, I mean, I guess you try to vary with your practice, but people say more than 3 in a year is a kind of is a general rule which has been clear.
Okay. Now one question from the pain control and from the rehabilitation. So if the patient come to you for rehabilitation, and those exercises which you think are important for them, they're gonna hurt, would you still offer them those exercises which should take stronger painkillers to do those exercises, or they should just wait for the pain to get better before they can start any rehabilitation? That's where usually the catch is.
Yeah, so you kind of have that open, honest discussion with the patient, and kind of sometimes people will want to take the painkillers to try and just push through it. But my first line of approach will always be regress the exercises to the point it's at a tolerable enough pain level. So that doesn't mean that if someone's doing an exercise it has to be pain-free, but it should be between that kind of 3 to kind of 5, 6 out of 10 pain mark where they're pushing their muscle to that point that it's causing some type of changes, but not the point that they're in agony.
And the role of local anesthetic patches, or giving them a steroid so they can do the exercises. Again, those are all kind of controversial topics, but again, it's the pain which is stopping and inhibiting the muscles.
Yeah, and that's kind of where from a physio rehab point of view, you start with more isometrics, which is where obviously the kind of muscle's working, but it's not actually to the point that the muscle's lengthening or shortening. And you find that that helps kind of dumb down some of the pain sensors, so they can get the exercise a bit more tolerable level. So that's how the work of Jill Cook, who did like a load of stuff with patellar tendinopathy patients, where they do like a 30-second isometric, and then do the rehab exercise afterwards, and they found that their kind of pain levels and symptoms satisfactorily dropped down to the point they could continue on the rehab.
I think that's a big problem what you alluded to. Patients don't engage with physio because it hurts, and then physios also quite often say they give up on that, I can't do any more, and they send patients to surgeon. And I mean, one patient worries they think they're damaging their joints, and I think that's pretty much kind of that needs to be taken out of their mind. By exercising, you're not damaging the joint. I know it hurts, but you're not damaging. Obviously, they can exercise smarter. If they have to do squats rather than doing a full squats, if they do half squats or whatever within their limits, they can. But as they engage and they push more, actually the threshold for doing exercises gets better. I mean, that of course needs to be explained to the patient, and obviously you have to find time to do that. But exercise harder and smarter actually makes them better.
Exercise smarter, harder but smarter, and that's the bottom line. Very good. I think again it's just a generic question. So meniscal repairs, what would be your indication for meniscal repair rather than partial meniscectomies?
Pretty much all young patients, we would go for with the kind of plan for repair. So all of them get consented for repair. I mean, meniscus is there to protect the joint and prevent future risk of arthritis. So a young patient, its primary aim is repair, and it will be unusual to take it out. Obviously, you have to. Classic indication is a peripheral longitudinal tear in a vascular zone, which means a periphery. That means it's a potential to heal. In my practice, I've got pretty much young patients. We stretch these indications, and any source of tear, unless obviously the point can't repair it, then we aim to repair them.
Do you use any meniscal scaffolds or meniscal replacements?
I have done few, but I've done not masses of scaffolds.
If you do any, then would you support them with any biologics or just by themselves?
There is a lot of blood in the joint anyway at the time.
You just rely on it. Okay, that's very good. Okay. Right, okay. Acute ACL injury, again, as just an overview. So I think you already mentioned, highlighted. So patients presented or have an ACL injury. In your setting, do you have one-stop clinics, physio-led clinics, or what stage will they be referred on to you? Will they go through the rehab before they're referred on to you, or you refer them to the rehab?
So no, we got a knee injury clinic, which is actually a mixture of physio and surgeon. So we consider our physios equal as our surgeons. So they're not that some of the minor injuries get sent to physios and major goes to our surgeon. So the same pool, they can either go to physio clinic or my clinic. So we have access from A&E, we have access from GP, and of course we have access from our other colleagues. So as they come acutely, so is the question was that.
So I think again, would you remember you mentioned again looking at the socioeconomic aspects?
Yeah.
That
But
would
you
they
go
refer-
acutely to surgery? Is that what the question is?
That would be the next question. So at the moment is somebody with ACL injury, they've been referred to you. What would you do? Would you send them for prehab? Would you look at their
Look,
activity level and then offer
Obviously,
them
no.
reconstruction?
First thing is, obviously, once you confirm, presumably you confirm the diagnosis, you talk to patient and see what their one is understanding of injury, what their expectation is, what their activity profile is. Then you always explain to them, obviously, operative and non-operative options. But there are a group of patients who are involved in a lot of cutting maneuvers, sports which involve lots of cutting things, and as a routine, I would always try to send them for non-operative option first. Obviously, one is you never operate acutely unless they have a meniscal pathology which dictates that you need to go acutely. You want to get them a full range of pain-free movement. So I'll send them all of them for prehab anyway. But so it's become like if they come to you 6 to 8 weeks where they've got the full movement, then it's a matter of discussion with them. And if they have symptoms, it's easy. Then they want to go for surgery. But if they don't have symptoms, you talk to them, and some patients choose to go directly for surgery. They say, I don't think so I'll be able to go. Most patients, I would encourage them to at least give a try to physio, and then make a call and based on the symptoms. But if they have a meniscal pathology, actually that dictates whether if I need to repair the meniscus, then I would recommend that they need to get surgery done sooner.
But do you do at the same setting or do you do a separate procedure? Meniscal repair with ACL.
I mean, if anybody does separate setting, it's unethical practice.
Right. Now, for the rehabilitation, prehabilitation, is it all time-based, activity-based?
Activity-based, so I kind of just a system in place that I kind of go through, obviously in the pain side of things under control, education side of things, and then from the prehab side, make sure that they're quite strong, and then working up in terms of kind of plyometric-wise, can they actually absorb force and can they produce force, and then discuss about kind of different stages of rehab, and as I alluded to earlier on, kind of looking at is it a case that the player is a winger or a position in sport that they need that speed, so we start introducing components of the exercises but more about speed, which is going to help them get back to not only their sport but their specific position in the sport as well quicker.
So they return to sport, you sign them off, they return to sport, and then they have another episode of instability. Would they still need to go through the prehab, or would they still need to go through the rehab, or would you offer them surgery now? Or is there, what I'm trying to say, is there any role of other period of rehabilitation after a successful initial?
There is always a role for another period of rehabilitation. There is always, as I said, I mean, obviously sometimes the meniscus dictates, but otherwise there's always a role for other rehabilitation.
Very good. After your ACL reconstructions, what would you tell them about when to return to sport, or is it whatever the physios guide us?
Okay. Obviously, it's not a time-bound thing. It's usually kind of goals oriented, really, whether they can achieve those goals. But if I have to just, the patient like to know roughly what, because with their work commitment, so I normally or tell them sports is 1 year as a routine. I mean, the evidence is that if you go before 9 months, there's a high risk of re-rupture. But they still have to reach all those landmarks, the different tests, half-half tests, and the 3 kind of triple half, and all those tests. But minimum 9. What I do is tell them at 9 months you start doing your sports specific. Obviously, they start before as well, but you then start thinking of returning to sports with the aim to do a competitive game at a year. That's what I'm.
Would you change your choice of graft depending on if the patient wants to return to sports earlier, if they're professional sports people?
I mean, I use a whole range of grafts for different patients. So I don't always change if they want to go back. If you may say that I've used a patellar tendon for those patients early, no, I don't.
Okay. Right. Now, there will be few younger patients who are having knee replacements. Hopefully they will avoid that. But if they wanted to return to sport, are there any restrictions? Can they do golf? Can they do tennis? Can they do swimming? Can they do skiing?
Yes, to a degree they can all do. They will have, most of them, I mean, the artificial joints do limit their activities to a degree, and most people find their kind of a functional kind of middle path really, which their joint would allow and what they can achieve. So it's okay what they can do. They're not going to ski at the same level which they did when they were 20 years back. So they all find their own happy medium really, what they can achieve.
Again, I have a patient who came in. They said, "I want to go back skiing after total knee replacement." I said, "You can, but."
Yeah, you're not bending your knee that much, you're not twisting that much. Some of them opt to use a brace at the same time. So you can, I mean, you don't always all have to be expert skiers really.
Probably. Right. Now there are probably some controversial questions. Do you see any role of tissue engineering, 3D tissue engineering in future for any of the knee pathologies?
Yeah, I mean, a lot is happening in that field. I mean, I would be surprised if there is no role really. I mean, there is I mean, we're talking more and more about personalized approaches.
Yeah.
So there is definitely a lot is big. I mean, even obviously grafts, soft tissue grafts with the arthroplasties. I mean, there's a lot of work happening.
Right. Thank you for that. So coming to the ankle sprains now. I think you already highlighted how would you assess the patient have presented with ankle sprains. So how many ankle sprains before you say now there is a problem? Or what's your practice? What do you see?
So what I normally see is like Mr. Anand was saying, I've set up an acute ankle injury clinic now. So what we have is access from 2 or 3 different sources, and let's say if a patient has the first injury, then the patient is usually assessed in our clinic, or the patient might have been seen by the physio. We normally give a trial of non-operative management for these patients initially with a boot, cam boot, and then they start rehab at about 2 or 3 weeks, and we give a full physio up until 3 months. Now, like I mentioned earlier on, majority of them will settle down and don't get a second episode, but 20-30% of these patients tend to go in the chronic laxity, but that chronic laxity is usually not evident until about 6 months are gone. So they may have some episodes of recurrent inversion injuries, but it may not be as bad as the first one. So they tend to manage it by themselves. But if it carries on after 6 months, then that is when you start thinking about investigating them a bit more.
So if they're presented with ankle instability and they've been referred to you, so what would you advise them, and how would you plan their rehabilitation?
So kind of I find the ankle instability ones, the majority of them kind of, it's like a reactive side of things. So you have your copers and non-copers with the ankle sprains, and as you're saying, it's like they tend to kind of flare up but then recover quite quickly. So it tends to be a lot to do with kind of speed, hopping type drills. Kind of you're getting them that kind of reactivity of the muscle, because ultimately if you just do slow, steady, predictable type exercises, that doesn't replicate them getting back to their sport or their activity, because it's more that kind of sudden reactive kind of component that you need to train.
And then do you use any dynamometers, any digital sensors, or any gait analysis in your practice, or in the management of those patients?
Gait analysis, yes, not so much the dynamometers. But gait analysis quite a bit, yeah. and then just breaking down, deconstructing the kind of gait cycle in terms of are they kind of not pushing off appropriately, and kind of adding in then kind of different gradients, stairs, steps, and so forth.
So, Mr. Lam, when would you advise them to return to sport after?
So again, it
stabilization?
depends on which ligaments are damaged. And like I mentioned, if I see them and grade them clinically as a stage 1 or type 1, then they rehabilitate faster. And by 3 months, I'm usually happy for them to return into sports. Not at competitive level, obviously, but recreational sports, yes, absolutely fine. But the more and more lax they are, then you are on a more conservative side. So usually by 6 months, and by 6 months, if they return to sport and they come back with additional problems again or recurrent instabilities, then that is when I start to think more about the chronic laxity. But usually what happens is the ankle injuries now, we tend to get the MRI scanner much quicker than previously. Previously, the patient used to go quite a bit of them to physio first, and then the physios usually had them for 4 or 5 months, and then during that time they used to get the scan done. But with the acute injury clinics now, we tend to isolate the grade 3s or grade 2s earlier and get the scans done earlier, mainly, like I mentioned earlier on, to rule out cartilage pathologies, problems with loose bodies and fixation, fragments that can be fixed earlier on. And I think sometimes the early intervention is better than the long-term rehab in that sense. So there are certain strict indications where I would tend to go in earlier. So for example, types like Maisonneuve's injuries, where there's a syndesmotic tear and it goes through the membrane, the synovial membrane, as well as a fracture of the fibula at the top end. These are the ones where we tend to interact quicker. Yeah.
If patients having hypermobility or generalized ligamentous laxity,
Yeah.
will you change your rehabilitation after ankle stability, or would you change what type of stabilization would you do for those patients?
No, I don't change it. No.
Achilles tendinopathy.
Yeah.
How frequent you see them?
Well, it's a very frequent presentation into the clinic now. Essentially, there are 2 different varieties. Then they present with insertional, like a Haglund's lump, or they present with the non-insertional tendinopathies. They're both equally common. There's a sufficient literature now which suggests that non-operative treatment works well with non-insertional. And we currently I'm a part of the multi-center trial for the PRP study, like Sanjeev is, and we are doing the PRP for non-insertional tendinopathy, and we've recruited nationally about 200 patients now and waiting for the outcome results. As regards to the insertional tendinopathy, as I mentioned to some of these delegates earlier on, that these are the patients who have large lump at the back of the heel, and that is causing the pain. So there are better techniques of removing these and repairing the tendon much better. So you can take the tendon down without any major concerns. Now you can remove that large lump of bone, repair the tendon, and if necessary, augment that primarily with the flexor hallucis longus tendon transfer.
Very good. So again, you're doing the biologics as part of the trial, but not
Yes,
as a routine.
but as a part of the trial, no, not as a routine. No.
And again, off the record, do you see any difference in their rehabilitation?
Well, that's a very good question. We have also tried the Ostenil injection for 20 patients now for non-insertional, and we are completing the audit now and hopefully presenting that's the first UK trial for Ostenil injection for non-insertional tendinopathy versus the PRP would be compared at some stage. The outcomes with the hyaluronic acid or the ostenal tendon is encouraging. However, the results are early.
Now, we're coming to the end now. So a patient referred to you with plantar fasciitis. She's an overweight patient.
Yeah.
Who's on their feet
Yeah.
for most of the job. And they've tried and they failed to lose weight. What would you do?
Well, it's a difficult one to manage. I personally, in that sort of patient profile, stay away from the surgery. The problem is that they will keep coming back to you, and then you will have to stop injecting them at some stage, because it then causes more damage to the plantar fascia. But on the other hand, if you think it that way, if you keep injecting in the same spot over and over and over, it essentially ruptures and does the same job that the
It's a
surgeon
surgery,
does.
but slow
So
surgery.
essentially, it is a slow surgery, and if that fails, the patient doesn't sue you. That's the benefit.
Right, okay, I think that's a good point to learn. Okay.
So I think surgery is probably best avoided to these.
Now, we asked this question in our polling session as well. So, any role of ultrasounds in your practice
For the
for the
ten-
rehabilitation part?
For the rehabilitation, not frequently, not routinely. On occasions, we've had patients having some lateral gutter pain following the modified Brostrom reconstructions, partly because of the new technique, that internal brace that we are using. Sometimes we initially had over tightening of these ligaments, and that's the cause of the pain in the lateral gutter. So these respond very well to ultrasound therapy or even a short injection in that region. But what we do now is that we keep it slightly lax as opposed to what we did before, and my patients are not that painful anymore.
Is that just a subjective thing?
I think it is more
intraoperatively or-
subjective, yeah. Yeah.
Any role of restricting blood flow? We talked about in upper limb. Any role in the lower limb?
I don't think so.
No.
No.
From the rehab point of view?
Yeah, so there's some stuff coming through from a muscle hypertrophy standpoint, around quadriceps, so obviously occlusive training, so you put on kind of tube grip around the kind of quads, then do kind of a protocol that they have preset, and then kind of take it off, and it's postulated that it's kind of help with hypertrophy. As I said, in upper limbs, it's not about hypertrophy, it's more about the muscle strength, but you may have some kind of role for it from a knee perspective or a calf perspective down the line.
Good. Last question. What pathology not to miss in the knee? Starting Mr. Anand.
I think it's important that younger patients don't miss swelling after injury.
Okay. And how to avoid it? Good history taking, examination, or an
You just
investigation?
have to ask one question: did you hurt your knee? Did your knee swell up? And just look at the knee swollen.
Okay, thank you. And from the ankle point of view, what not to miss?
I think that's the same thing. The history is very important, and the patients usually come with a specific complaint. I think if you listen to their instability pattern, you can pick it up very early. The problem is that if the patients keep coming, then they will start to get osteochondral lesions, and that's not to miss. So do a scan earlier.
Right, okay. And from the hip point of view,
From
not to
hip-
miss?
So you're obviously thinking red flags, so any kind of trauma, any AVN type stuff, and then kind of from it's on the top of that. No. But just make sure, actually, as I said about the history, it's the history of the rehab as well. So sometimes if a patient does come in and say that they've tried physio, it's understanding as what they actually did as part of the physio, because if they just did solely ultrasound, that's not physio.
And I think again that's an important point. If you are across in the country, not all the rehabilitation or physios are the same. So if the patient says I have physio, it doesn't matter. It doesn't mean anything what they have. So I think you need to dissect it down what exactly they have and whether that they have the right physiotherapy. Right, very good. Any further questions about the hip, knee, ankle from anybody before we close this session? Yeah.
In regards to the ankle, what biomechanical factors give you an increased risk of chronic ankle instability?
That's a very good question. Like I mentioned earlier on, people with cavus feet are at a very high risk of damaging their ligaments because of the position of the foot itself. As I mentioned earlier on, the medial side is less common than the lateral side. So if somebody is in a cavus foot, they are likely, and most of these patients in their mid-30s to early 40s will start to get problems in the ankle. The second group of patients that I see a lot of these things is the ligamentous hyperlax patients, where you have to grade them it's a modified Bateman scoring, so you grade their laxity and just find out if they are over 6 or 7 out of 9, and these are the patients who you have to keep a close eye on, because these are the patients who will get ligament problems. So third thing that I see nowadays is biomechanically, if if people are doing a lot of pointing sort of exercises or sports that involves pointing down, these are the biomechanically very unstable ankles.
From a physio standpoint, kind of looking at biomechanically, you can just see, like, look at wear patterns on the shoes, because that kind of tells the story as such. So if you are kind of looking at the wear patterns and seeing lots of wearing in their kind of heel counter, lots of wearing on the lateral aspect, they're probably more likely that they're going to have a more prone to kind of ankle sprain kind of laterally, and then just seen from the kind of toe off as well. So if they are kind of toeing off from that side, at least it's a bit more balanced. But you might need to train that, actually train doing a lunge and reaching across their body to get more weight bearing down through the hallux and down through the medial foot.
Right, that's very good. Thank you very much for that.
Thank you.
Thank you.